All right. Good morning, everybody. Thank you so much for coming to the first session today, especially after Movie World. And thank you for the introduction, Steve. My name's Tamishta. I'm an intensive care trainee from Victoria. And today I'll be presenting the results of a study that we performed investigating the utility of Haematocrit as a guide for fluid resuscitation in pancreatitis. Acute pancreatitis is a disease often accompanied by a reduction in circulating volume. Now, this can be the consequence of vomiting, reduced oral intake, as well as plasma leak through compromised endothelium as a component of the systemic inflammatory response. A treatment priority in acute pancreatitis is to ensure an adequate circulating volume, and this is usually provided as intravenous fluid. However, it remains unclear how best to determine the volume of fluid to provide a patient with pancreatitis. If too little volume is given, then inadequate blood flow could exacerbate pancreatic ischemia and necrosis. But conversely, excess volume could also exacerbate endothelial changes and intensify the multi-organ dysfunction. Haematocrit and its changes over time have been considered to represent hemoconcentration or hemodilution, and a number of guidelines have suggested using the change in hematocrit to guide volume of fluid replacement in acute pancreatitis. But despite these recommendations in quite high-impact journals, there's actually very little to no evidence to support the utility of using hematocrit to guide intravenous therapy in this disease. So to further understand the clinical utility of hematocrit in acute pancreatitis, we conducted a retrospective observational cohort study. The aims of this study were twofold. So first of all, to look at the association between the change in hematocrit over 48 hours and volume of intravenous fluid administered. And the second, to look at change in hematocrit over the same period of time and its association or relationship with mortality outcomes. To do this, we conducted, as I said, a retrospective cohort study, and we used the MIMIC3 database. Now, MIMIC3 contains a repository of data collected from over 25,000 patients admitted to the intensive care unit at the Beth Israel Deaconess Medical Center in Boston between 2001 and 2007. Variables in the data set include physiological parameters, patient demographics, fluid, other therapies administered, pathology tests, and patient outcomes. Institutions governing the use of MIMIC3 waived the need for ethics approval, and all investigators signed a data use agreement prior to data access. The cohort studied were patients with an ICU diagnosis of acute pancreatitis, and that was defined using ICD-9 codes. Descriptors of our cohort included patient demographics and markers of severity of disease. For the primary analysis, we collected 3 hematocrit values. First of all, T0, which was hematocrit closest in time to ICU admission. T24, which was hematocrit nearest in time to 24 hours of ICU admission. And T48, which was hematocrit nearest in time to 48 hours of ICU admission. The volume and type of intravenous fluid administered at the corresponding time points was also determined. The outcomes we examined were in-hospital and 90-day mortality. So on to results. A total of 435 patients were identified with a diagnosis of acute pancreatitis. Patients were excluded if they were pregnant or administered packed red blood cells, and this left a cohort of 301 patients for analysis. The cohort had a mean age of 57.5 years, median weight of 83.5 kilos, 57.8% were male, 10% received vasoactive agents, and the median length of stay was 4.4 days. The mean hematocrit at ICU admission was 35.3%, and this decreased over time to 32.2% at 24 hours and 30.8% at 48 hours. The decrease was statistically significant with a p-value less than 0.01. Over the corresponding points in time, a median of 5,330 mils of intravenous fluid was administered over 24 hours, and a total of 8,025 mils over 48 hours. 77% of this administered fluid was crystalloid. This is probably the most exciting slide. The change in hematocrit, as you can see there, had a weak negative association with the volume of intravenous therapy administered, and this is quantified by the Spearman's correlation factor of negative 0.31. The relationship was statistically significant with a p-value less than 0.01. Now, in regards to our second aim, in-hospital mortality was 11% and 15% at 90 days. On multivariate logistic regression, hematocrit change over 48 hours had no statistically significant association with either in-hospital or 90-day mortality. The covariates that we considered were selected using a forward and backward stepwise selection method. So in-hospital mortality was adjusted for use of vasoactive drug and baseline hematocrit, whilst 90-day mortality considered the use of vasoactives, baseline hematocrit, age, and whether they'd received colloid. So to further explore the prognostic use of hematocrit, we did a sensitivity analysis. So essentially, we hypothesised that there would be two at-risk groups. So first of all, those patients with high hematocrit who didn't get very much fluid, and those with a low hematocrit who got a lot of fluid. And to explore this, we constructed a 2x2 table comparing the mortality rates for the upper and lower quartiles of baseline hematocrit and fluid administration. This analysis showed no mortality difference. So how do our results compare to other work? Well, very interestingly, a recently presented post-hoc study of patients with septic shock in the ARISE trial reported a decline in haemoglobin that also had a very weak association with the volume of fluid administered. In that study, only 10% of the decline in haemoglobin could be explained by the volume of fluid given. So I can hear you ask, what could account for the decline in hematocrit if it wasn't fluids? Thanks for that question. Possible contributors could include the resolution of the SIRS process with interstitial or third space fluid returning back into the intravascular space. Treatment of vomiting could also reduce extracorporeal fluid loss. And potentially physiological AD8 secretion might be a delayed response that could have contributed with its renal preservation of water. Our study had several strengths. First of all, it provided our group an opportunity to utilise MIMIC3 database and explore its capabilities. It was an excellent opportunity to understand big data, its advantages and limitations. We had a large representative group of patients. Now, there have only been a handful, literally a handful, of studies looking at the utility of hematocrit as a prognostic tool, and there's been one study that looked at other guides of clinical guides to guide fluid resuscitation in pancreatitis, and at most these studies contained less than 130 patients. The mortality rate is also comparable to that in an Australian population. In the ANZICS APD, in-hospital mortality was 12.13%. The MIMIC database contained timing of all therapeutic interventions and investigations and allowed us to pair timing of hematocrit measurements with fluid input. So a study strength is the accuracy in timing the relationship between the two variables. We did have some weaknesses. First of all, the retrospective observational nature of this study, which is probably its principal weakness. It increased the risk of selection bias. We only used case-complete patients and measurement error. Apache scores were not available in the MIMIC3 database, and so we couldn't use this as a covariate to describe or control for the severity of disease in our cohort. However, we are working on an algorithm to enable us to be able to publish this in the future. Lastly, our study only included data from time of ICU admission and probably didn't capture initial resuscitation efforts. So it might explain why, first of all, the hematocrit at T0 was lower than expected, and it also might have weakened the observed associations. So in conclusion, whilst the relationship between hematocrit and intravenous fluid volume was statistically significant, the correlation was weak. This would suggest that it's a poor guide for guiding fluid resuscitation. Furthermore, there were no significant associations between change in hematocrit and mortality. We conclude that change in hematocrit is of limited clinical utility in acute pancreatitis. I'd like to acknowledge the rest of my research team who were instrumental to this study and made it run really as smooth as a cashew. First of all, Tamir and Stephen, who are data scientists from Swinburne, Zachary, who's a very clever medical student from Monash, and Matt Maiden, an intensivist from the Geelong and Royal Adelaide hospitals. And finally, a very big thank you to ANZICS. This project was birthed at the ANZICS organised Datathon, which helped to facilitate our access to MIMIC3 as well as the ANZICS APD. Thanks.
There's a full 5 minutes for questions.
Pancreatitis is often a smouldering, waxing, waning disease, even in a nuclear ICU patient. Do you think anything that we
It's a good question. Unfortunately, the way that the database is set up, we weren't able to tell exactly when they had come into hospital. So we can't even tell where in their sort of the story of pancreatitis we're capturing these patients. The second thing is, certainly in other studies, perhaps there's more of an association in that initial 24 hours. In the ARISE study, it was in the first 6 to 8 hours. So if anything, I would wonder whether we actually need to shorten the time frame rather than lengthen it out.
Great presentation. Is there any future research that you'd like to do based on this study?
Yeah, quite a lot. I guess, first of all, having a prospective trial and starting that trial from arrival in ED or from the start of the resuscitative efforts. As I said, we'd like to shorten the time frame, so look at less than 24 hours. And I guess sort of wider implications of the work are looking at hematocrit in other diseases like sepsis.
Tamishta, thanks. You showed that there was quite a lot of variability in the hematocrit and fluids, but there was a consistent relationship overall. Was there anything in your data that accounted for that variability, such as gender difference or size of the patients or anything like that?
Not that we found. Certainly with the mortality outcomes, we also did an exploratory analysis to control for age, weight, other sort of lactate and creatinine, and we saw no change in the relationships that we saw. We haven't looked at whether, to be honest, we haven't looked at how it's affected the variability of the actual hematocrit or the relationship with intravenous therapy. Sorry, I'll just add to that. The only other thing we saw was we did look at fluid administered in relation to weight, and it looks like weight wasn't taken into consideration at all.
As in, people didn't alter the amount of fluid that they gave?
Depending on the weight of the patient.
Okay.
Yeah. Yeah.
Tamishta, since no one else is asking a question, analysis of change is very difficult, actually. Do you know anything about the natural phenomenon regression to the mean when analysing change?
I don't know much about that. Sorry, I'd have to get you back to you.
Did you have baseline haemoglobins in your model?
We
or
didn't.
Did you model change? Yep. Okay.
Yeah, we modelled change.
Professor Dean.
So how will diagnosis of pancreatitis made and how certain are you with the diagnosis?
It's a good question. So we used the ICD-9 coding, which was an admission diagnosis. So first of all, because it's a retrospective database, there's going to be inherent sort of accuracy errors with the recording of data. We did look at lipase as well, an admission lipase. Interestingly, it was actually missing for a lot of patients, or was not diagnostic of pancreatitis for some patients, which sort of confirms our belief that we're just capturing that initial resuscitative effort that was done before they came into the department. But it is potentially a limitation of the study that we can't really assess that.
Nice following on from that. Do you know how many patients may have complications such as sepsis complicating their severe pancreatitis?
We haven't looked at that.
Do you control for any of the other factors scored for in the Ranson-Emery criteria, such as calcium?
We actually chose not to look at the Ranson-Emery criteria only because Apache has been much better validated in acute pancreatitis, certainly in the acute longer phase, as well as the fact that it requires 48-hour measurement. So we haven't actually looked at things like calcium.